Hello, and thank you for joining. I'm Lindsay Denny, and this is an overview presentation of WASH, Water, Sanitation, and Hygiene in Healthcare Facilities. This webinar is a part of the WASH in Healthcare Facilities initiative, an action-oriented learning platform that brings together the WASH and health communities to focus on policy, evidence, and practice in WASH and healthcare facilities. One aspect is a monthly webinar series, where we hope to connect partners, share experiences, and encourage groups to act. Our goal is to expand the conversation, connecting the expertise and experience of our partners and colleagues to the members of the WASH and health community, especially those in country, who have expressed interest in moving to action on WASH and healthcare facilities. We welcome all to participate in these webinars, whether you're a seasoned expert or someone for whom this topic is brand new. WASH in healthcare facilities is a complex issue, and there are many angles to discuss. Each one-hour webinar will focus on a single topic and speaker, allowing 30 minutes for discussion. We want to make the most of our time, so rather than introducing background information each month, we've recorded this webinar to give you a comprehensive overview of WASH in healthcare facilities. For those of you who are less informed on the issues, we recommend you listen in full in order to get the most out of the monthly webinars. The WASH in Healthcare Facilities initiative is organized and hosted by the Center for Global Safe Water, Sanitation, and Hygiene at Emory University and funded by the General Electric Foundation. It's important to us that this initiative benefits anyone seeking to improve WASH in healthcare facilities. Therefore, all materials are open source. The webinars will be recorded and the slides will be available for download. The objectives of this webinar are to describe the scope of WASH in healthcare facilities, to consider why WASH is a crucial component of a healthcare facility, to discuss linkages between WASH and healthcare facilities and other health topics, to review WHO and UNICEF's Global Action Plan, and to consider ways in which you can take action. In 2008, the World Health Organization published the Essential Environmental Health Standards in Healthcare. It says, healthcare settings are environments with a high prevalence of infectious disease agents. Patients, staff, carers, and neighbors of the healthcare setting face unacceptable risks of infection if environmental health is inadequate. The healthcare setting might even become the epicenter of outbreaks of certain diseases, such as typhus or diarrhea. If this document had been written after 2014, it may have mentioned Ebola as one of those diseases. This document provides the original standards for WASH in healthcare facilities, also highlighting the importance of infection prevention and control and hygiene in a healthcare setting. What is WASH in healthcare facilities? We define it as WASH, water, sanitation, and hygiene, infrastructure, resources, services, and practices in a healthcare setting. What is a healthcare setting? We define this as anywhere healthcare is provided, including health posts, health centers, clinics, dispensaries, and hospitals. The specific services provided at these levels may vary by country. Facilities may be publicly managed, such as by the Ministry of Health, or privately, such as private for-profit or a faith-based organization. What does WASH encompass in a healthcare facility? It includes water, so the source of water and access, how it is stored and distributed through pipes or through buckets, the quantity of water, and then the quality of water, whether it is safe to drink and used for other purposes. Sanitation includes the access to toilets and latrines, the quantity of these facilities, whether or not they are hygienic, the quality of them, the fecal waste management, how the feces is safely managed, and then healthcare waste management, which looks at the management of sharps and infectious waste specific to the healthcare setting. Hygiene includes hand hygiene, so hand washing and the use of hand sanitizer, bathing, and then infection control measures such as environmental cleaning practices and the disinfection of medical equipment. What are examples of infrastructure, resources, and services and practices? Infrastructure includes the physical facility, so latrines, sinks, pipes, water treatment. Resources include consumable supplies such as chlorine, as well as human resources such as cleaning staff and maintenance staff. Services may include drinking water availability, and practices such as infection control measures of hand washing and environmental equipment processing. WASH in healthcare facilities has therefore been broken down into 5 major categories, including water, sanitation, hygiene, environmental cleaning, and healthcare waste management. This map provides a visual representation of the complexity of WASH in healthcare facilities. There is no one way to go about improving WASH in healthcare facilities because there isn't just one issue to be addressed. In the webinar series, we will be considering these different issues and angles at which you can approach WASH in healthcare facilities, and consider best practices for each as we discuss experiences and lessons learned. Throughout this presentation, and as you develop your own program, it's important to think about sustainability. What will the WASH conditions and practices in the healthcare facility look like over time? Installing a water treatment system or building a toilet does not fully address the gaps in WASH. Ensuring that WASH infrastructure, resources, services, and practices are not only introduced but maintained is an important part of any improvement plan. Additionally, by understanding the systemic causes which led to these gaps and addressing them, it's more likely that the WASH intervention will be sustainable. WHO released the Essential Environmental Health Standards in Healthcare in 2008. It would be another few years, though, before the issue was carried much further. In 2014, WHO and UNICEF hosted a meeting on WASH in healthcare facilities, and in 2015, they released a joint report on the status in low and middle-income countries, which brought the issue to the attention of the global community. However, the report noted that limited data were available, and therefore, getting a clear picture of the status of WASH in healthcare facilities globally would take some time. This table provides the coverage data from the 2015 status report. Water coverage is reported at 61%, sanitation at 82%, and hygiene at 65%. While these numbers are already disturbingly low, it's important to take a look at the indicators and understand the nuances of the phrasing. For example, access to an improved water source within 500 meters for water. An improved water source, for those of you unfamiliar with WASH, is a source that by nature of construction or through active intervention is protected from outside contamination, particularly fecal matter. Access to an improved water source within 500 meters is an indicator written for communities and has been determined to be inappropriate for healthcare facilities. The water indicator has since been rewritten as access to an improved water source on premises. We need to take these definitions into consideration when using the data to be sure we depict an accurate picture of the status of WASH in healthcare facilities. In January 2018, the University of North Carolina at Chapel Hill published an expansion of the original 2015 status report. This article includes data from 78 countries and more than 120,000 facilities, or nearly double the number in the original report. They've also included 21 indicators on environmental health, focusing not just on water on premises, but also indicators like piped water into the facility. The table here provides the coverage data from the 2018 article from UNC. It's important first to note that I've taken away the indicator for water that said access to an improved water source within 500 meters, because the community agreed that that was not a sufficient indicator for water in healthcare facilities, and I've replaced that with access to piped water, which was reported at 50%. Access to an improved sanitation facilities has decreased from 82% down to 67%. Access to soap for hand washing has stayed about the same at 61%. And then you'll note that adequate sterilization equipment for medical equipment has decreased from 55% down to 27%. The data in this article is the most comprehensive data available on the coverage of WASH in healthcare facilities. It provides an overview of the situation and provides information on where there are gaps. However, it still doesn't tell the whole story. The landmark 2015 status report from WHO and UNICEF laid the foundation for global action, and the 2018 UNC article provided further evidence regarding the lack of basic WASH in healthcare facilities. Both of these documents and the data from them have helped spur the global community to take action on this issue. However, because of the data available, neither report considered issues beyond coverage of WASH. So what are issues beyond basic coverage of WASH? Well, that might include the functionality of WASH facilities like broken sinks, the quality of WASH facilities such as hygienic toilets, the accessibility of WASH facilities such as accessibility for those with reduced mobility or locked toilets, and quantity of WASH facilities such as the number of toilets to the number of patients. It may also deal with issues of water shortages, water quality, the hygienic conditions of the facility, such as the wards, the toilets, and the facility premises, and WASH-related behaviors such as hand washing. But why is WASH so important in a healthcare facility? Which facility activities really need WASH? That list includes hand washing, the cleaning of floors and surfaces with soap and water and disinfectant, disinfecting and sterilizing medical equipment, cleaning wounds, disposing of hazardous waste, bathing, drinking water, or taking oral medications. The use in medical devices, such as CPAP machine, which requires water, both for the use of the machine and to clean the machine, laboratory purposes, and using sanitation facilities. There are, of course, both opportunities and challenges in addressing WASH in healthcare facilities related to the context of the healthcare setting. One of the primary challenges is that within the healthcare facility walls are vulnerable patients mixed with a high density of pathogens, hazardous waste, and contaminated areas. There's also specific requirements due to the limited mobility of patients. Healthcare facilities are diverse. There's various levels of facility, from health posts up to hospitals, which provide different services. There's a variety of users, patients, staff, and visitors, as well as multiple uses for water, and a variety of wastes that are produced. Finally, WASH in healthcare facilities often falls between multiple sectors, like health and WASH or environment. In the past, roles and responsibilities have been unclear. There are also opportunities, though, in addressing WASH in healthcare facilities. For one, healthcare staff are highly credible and can promote hygiene behavior change among patients. Additionally, health facilities can function as a role model for good hygiene and proper waste management and water and sanitation management within the community. It's worth noting that we do see issues with WASH infrastructure in the developed world as well. In February of 2018, a mains leak caused water to be cut from 4 major hospitals in Manchester, UK. As precaution, the hospitals canceled all non-urgent surgeries because they understood the importance of cleanliness and water in preventing infection within those facilities. Bedpans, bottled water, and sanitary towels were provided to inpatients while staff were unable to sterilize medical equipment. The principles of WASH in health are not new. Physicians have been calling for improved hygiene as part of a strategy to reduce morbidity and mortality among patients for hundreds of years. For those of you who know a bit about medical history, you may remember Alexander Gordon, who in the late 1700s asserted that death from puerperal fever, or childbed fever, could be prevented with greater cleanliness, and that nurses and physicians ought to wash themselves carefully after contact with patients. In the 1800s, Ignaz Semmelweis, now known as the father of infection control, reduced maternal deaths in healthcare facilities in Austria by requiring doctors to wash their hands with chlorine solution. These days, we talk about the intersection between WASH and health, particularly WASH in healthcare facilities, through a variety of topics and agenda items. In particular, maternal and newborn health, infection prevention and control, or IPC, universal health coverage, or UHC, quality of care, antimicrobial resistance, or AMR, hospital-acquired infections, also known as healthcare-acquired or healthcare-associated infections, previously known as nosocomial infections, as well as outbreaks and emergencies. As understood as far back as Alexander Gordon and Ignaz Semmelweis, the lack of basic WASH compromises the ability to provide safe healthcare services, such as childbirth and surgery, as well as to be able to prevent hospital-acquired infections. This diagram helps to visualize the relationships between WASH and the health sector. At the top, we have universal health coverage, UHC, and this is the idea that all people can access health services needed of sufficient quality to be effective, while also ensuring that the use of these services doesn't expose them to financial hardship. So as part of this foundation is quality of care, which is nationally defined, but it's based on the following components from WHO, that care is people-centered, safe, effective, efficient, equitable, timely, and integrated. 3 of these components, safe, effective, and efficient, require infection prevention and control. Infection prevention and control, or IPC behaviors, such as hand washing, environmental cleaning, equipment processing, and healthcare waste management, cannot be provided without WASH in healthcare facilities. UNICEF and WHO, among others, have encouraged mothers to give birth in facilities. Childbirth taking place at a healthcare facility has increased in the past 10 years, such that between 2011 and 2016, more than 50% of births globally were facility-based. Yet recent studies have found that WASH is inadequate in many healthcare facilities in low and middle-income countries, including in the labor wards. This begs the question of how safe it is for women to be giving birth in facilities where there's no water available for hand washing, for cleaning, for disinfecting, where there's no toilets for them to use, and no bathing facilities available for them to bathe before and after giving birth. This photo comes from a delivery room in a hospital in Afghanistan that I visited, where there's no access to water within the delivery room. Midwives have to go down the hallway to wash their hands. This design is not conducive to ensuring IPC protocols are strictly adhered to. Hospital-acquired infections are of particular concern when considering poor WASH and IPC in a healthcare facility. In 2005, a systematic review found that rates of hospital-acquired infections in newborns are as much as 20 times higher in resource-limited settings compared to developing country contexts. Inadequate environmental hygiene and low adherence to infection prevention and control were cited as potential explanations. Hospital-acquired infections aren't just costly and inconvenient, they can also be deadly. Globally, around 1 million deaths of mothers and babies per year may be related to unclean birthing practices. This accounts for more than a quarter of the neonatal deaths per year. It's important to recognize that hospital-acquired infections are not solely a developing country issue. While in developing countries, an estimated 1 in 6 patients, or nearly 16%, contracts a hospital-acquired infection during their stay at a healthcare facility. In developed countries, it's an estimated 1 in 15 patients. Globally, on average, 10% of patients are infected with a hospital-acquired infection during their stay. Throughout the world, WASH improvements, including infrastructure and training, as well as awareness raising, are needed to ensure that patients don't get sicker during their hospitalization. In summary, WASH and IPC in healthcare facilities are necessary components for the provision of safe, effective, and efficient healthcare, because poor WASH and IPC can lead to hospital-acquired infections, which in themselves can cause morbidity and mortality. They can also contribute to the high usage of antibiotics in order to treat these infections, and can lead to antimicrobial resistance, which also increases morbidity and mortality. Poor WASH and IPC can exacerbate outbreaks such as Ebola, which then lead to, again, greater morbidity and mortality, altogether also increasing healthcare-associated costs. There are additional consequences of poor WASH in healthcare facilities beyond the health impact. For the healthcare facility itself, there are increased healthcare-associated costs due to treating infections and to having patients stay longer than originally needed. There's also decreased budget for other facility priorities. For the individual who's either getting treatment or at the facility with a loved one, there's reduced school attendance, reduced work attendance, decreased salary, and reduced buying power. For the employer whose employees at the healthcare facility, there's reduced economic productivity. The Sustainable Development Goals, or SDGs, are a list of 17 global goals developed by the United Nations in 2015 as part of the 2030 Agenda for Sustainable Development. While WASH in healthcare facilities is not explicitly listed as one of the goals, it falls nicely into Goal 3 and Goal 6. Goal 3, Health and Well-being, includes targets such as decrease the number of deaths and illnesses attributed to unsafe WASH, reduce the global maternal mortality rate, end preventable deaths of newborns and children under 5 years of age, achieve universal health coverage, including access to quality essential healthcare services. Goal 6, Water and Sanitation, includes the target of achieving access to safe water, sanitation, and hygiene for all. WHO and UNICEF have decided to interpret the phrase for all to include institutions such as schools and healthcare facilities. At a World Water Day event in March 2018, Antonio Guterres, the United Nations Secretary General, made a call to action for WASH in healthcare facilities. He said, "Today I'm using the launch of the Water Action Decade to make a global call to action for water, sanitation, and hygiene, or WASH, in healthcare facilities. We must work to prevent the spread of disease. Improved water, sanitation, and hygiene in healthcare facilities is critical to this effort." In response to Secretary General Guterres' call to action, WHO and UNICEF have proposed revisions to their 2015 Global Action Plan for WASH in healthcare facilities. There is a vision that every health facility will have the necessary WASH services and practices in order to provide essential quality health services for everyone everywhere. In line with the SDGs, the target date for this vision is 2030. As part of the proposal, there are 5 action areas where the global community can provide support to those on the ground undertaking WASH in healthcare facilities activities. Additionally, there are plans to embed WASH in key existing health initiatives and frameworks to ensure sustainability. The final Global Action Plan will be rolled out in late 2018. As part of the Global Action Plan, WHO and UNICEF have developed what they call metrics for progress. These metrics provide a roadmap towards achieving the 2030 goal of universal WASH coverage in healthcare facilities. They are benchmark targets that allow for incremental change over time while creating an enabling environment for sustainability of WASH services and practices. An example of a metric for progress could be X number of countries that have guidelines and standards on WASH in healthcare facilities by 2024. The full list of metrics for progress will be included in the action plan that's rolled out later this year. Before we start talking about action, it's important to think about the gaps and challenges facing those addressing WASH in healthcare facilities. The first gap relates to inadequate policies. UN Water releases a report every 3 years on the Global Analysis and Assessment of Sanitation and Drinking Water, or the GLASS report. In 2017, the GLASS report found that of the 79 countries surveyed about their national policies and coverage targets, only 16% had national policies fully implemented and funded for drinking water, sanitation, and hygiene in healthcare facilities. Similarly, only 9 out of 79 had coverage targets of 100%, while nearly 2/3 of the countries didn't provide coverage targets at all. Meanwhile, insufficient budgets can pose a threat to the sustainability of any WASH intervention at a healthcare facility. Of the 25 governments that provided their budget allocations in the 2017 GLASS report, all the countries reported they had budgeted for drinking water and sanitation, but only 5 countries had budget allocations specifically for WASH in healthcare facilities. Similarly, only 6 countries had budgeted for WASH in schools, yet the aggregate WASH in schools budget was nearly 10 times more than the aggregate WASH in healthcare facilities budget. It's worth noting that these questions were asked on a WASH survey, so they may not have reached the health sector. Better information is needed from both sectors about their policies, targets, and budgets within country for WASH in healthcare facilities, as well as their coordination mechanisms to ensure they are not duplicating efforts. Now that we've talked about gaps and challenges, it's time to think about how to take action. The purpose of this webinar series is to hear from those of you in country who are working on WASH in healthcare facilities. By sharing our diverse experiences, exchanging challenges and successes, and discussing lessons learned, we hope to push the needle on this topic. This action-oriented webinar series reflects what we heard was a desire to spend more time on each unique topic. In the next few slides, I'll touch on some of these topics. We have only selected the first 3, however, for our webinar series. We are seeking feedback from you all on which topics are of most interest, so keep this in mind as I go through them, and we'd love to hear from you. Advocacy is one way to take action on WASH in healthcare facilities. Awareness around WASH in healthcare facilities is insufficient, both among the development community and within developing countries. Advocacy is needed to bring attention to this issue and to highlight possible solutions and next steps. Advocacy must be directed at both the WASH and health sectors, encouraging both sets of partners to integrate WASH in healthcare facilities into their strategies, plans, budgets, and projects. It's worth noting for those of you who are not working at the national level that it's still possible to advocate for WASH in healthcare facilities by working with the subnational government, community leaders, or the healthcare facilities themselves. Before designing a strategy for improvement, you'll need to know what the current status is of WASH in healthcare facilities. Conducting a baseline assessment specific to WASH in healthcare facilities will provide the data necessary to set targets and develop an action plan, after which routine monitoring is important to ensure that actions are underway to meet these targets. It's also important to help evaluate the sustainability of any intervention, whether it's capacity building or infrastructural improvements. In 2016, WHO and UNICEF's Joint Monitoring Program for Water Supply, Sanitation, and Hygiene, or JMP, developed WASH in healthcare facilities monitoring indicators. There are 5 indicators in total, one of which is still in draft format, and each has associated survey questions. Water is defined as water from an improved source is available on premises. For sanitation, improved sanitation facilities are available and usable, separated for patients and staff, separated for women and allowing for menstrual hygiene management, and meeting the needs of people with limited mobility. Hand hygiene is defined as hand hygiene materials, either a basin with soap and water or alcohol hand rub, are available at points of care and toilets. Environmental cleaning practices are still in draft format, but are currently written as written protocols for cleaning are available, and cleaning staff and healthcare providers have received training on cleaning procedures. And finally, healthcare waste is defined as waste is safely segregated into at least 3 bins in the consultation area, and sharps and infectious wastes are treated and disposed of safely. In addition to these indicators for the general facility, indicators specific to the delivery room will be finalized later this year. The JMP uses service ladders to differentiate the level of WASH service available in a given country. They are no service, limited service, basic service, and advanced service. For the purpose of meeting the SDGs by 2030 and the indicators on the previous slide, the goal is basic service. However, countries can define their own advanced service level as they see necessary. Another way to take action is through infrastructural improvements. Data show major gaps in WASH coverage globally. At the facility level, this will require improving the physical infrastructure. This may mean increasing access to water through new sources or through storage tanks, by expanding the piping network to ensure that wards have access to water, by increasing access to sinks so that hand washing is more available, by treating the water so that water is clean and safe, by building toilets that are functional, hygienic, and accessible to people with limited mobility, and by providing incinerators for waste management. All of these infrastructural improvements will require operation and maintenance to be sustainable. WHO and UNICEF have developed the WASH Facility Improvement Tool, also known as WASH Fit. It's a practical guide that provides a risk-based continuous improvement framework and associated tools for undertaking WASH improvements as part of wider quality improvements in healthcare facilities. It's a facility-level tool, and it includes 4 domains: water, sanitation, hygiene, and management. The 5-step process begins with creating a team, then moves on to conducting an assessment, prioritizing risks, implementing improvements, and evaluating those improvements. The focus on continuous improvements allows healthcare facilities to take a phased approach to reaching the basic service level recommendations from JMP, as well as ensuring sustainability of those improvements. Infrastructural improvements, while important, aren't the only way to address this issue. Adherence to protocols is also critical to the safety of a healthcare facility. WASH-related behaviors overlap with some of the key behaviors of infection prevention and control. This includes hand hygiene, medical equipment processing, environmental cleaning, and waste management. There are 2 main approaches to behavior change. First is increasing knowledge and awareness. This may be done through pre-service training, job orientation training, or annual training for health facility staff, including clinicians and cleaners. The second is to motivate behavior change to ensure that good practices are sustained. This may be done through adjusting poor attitudes, the management's monitoring of behaviors, peer evaluation, and friendly competition within and between facilities. Facility management and the ownership and accountability of the staff, including the director, will have an impact on any WASH intervention in a healthcare facility. Effective management systems are important for maintaining infrastructure and adhering to protocols. Let's take an example of a water treatment system installed in a hospital. If the director doesn't include chlorine for the system in the budget, he hasn't developed a supply chain to procure the chlorine, and he hasn't assigned someone to maintain the system, the likelihood that the health facility will continually produce safe water is reduced. Meanwhile, gaining the buy-in of the staff can build ownership of the WASH intervention. If the staff and director value safe water at the facility, they're more likely to take care of the system. Finally, holding staff accountable to one another as well as to a managing body helps to ensure that the WASH intervention is sustainable. If the director is required to report water quality test results to the Ministry of Health every quarter, he is held accountable for the system. In turn, the director will hold the maintenance staff accountable for keeping the system functioning properly. A healthcare facility is part of a larger community. Therefore, it's important to encourage the participation of that community throughout the improvement process. One way might be to engage the community to define dignified and equitable health service delivery and care, including the use of WASH services, in order to prioritize interventions and to contextualize appropriately. You may also want to support the staff to define a safe working environment. It must be one that follows international standards, but should also take into consideration their safety, the safety of their patients, and the quality of care they are able to provide. As with any development program, we want to ensure that the time and resources invested by all parties leads to sustainable change. This should be considered from the conception of any WASH intervention or program. There are multiple ways in which you may create an enabling environment for sustainability. Some examples include training on the maintenance of infrastructure, developing and monitoring of guidelines and protocols, encouraging healthcare facility leaders to become WASH champions, budgeting for WASH at the facility level, linking WASH to other health initiatives in which the Ministry of Health is already investing resources, and raising awareness of the issue among policymakers, healthcare facility workers, and community members. As those on the ground implement WASH improvements, additional research is needed, both in the form of more traditional academic research, looking at the problem and potential solutions, as well as through the gathering of knowledge of those on the ground. Potential research topics that need to be further addressed include the health impact of poor WASH in healthcare facilities, impact of interventions and best practices, enabling environments and sustainability of interventions, factors for success and drivers of behavior change, cost of WASH interventions, and the economic burden and additional consequences and costs of not doing WASH in healthcare facilities. One of the challenges previously mentioned is the fact that WASH in healthcare facilities doesn't fall nicely into one sector, which thereby causes unclear roles and responsibilities. In order to introduce sustainable WASH in healthcare facilities, cross-sector coordination with the various stakeholders is necessary. These stakeholders may include the Ministry of Health, the ministry responsible for WASH, such as the Ministry of Water, Environment, or Rural Development, and the Ministry of Finance, and all of these ministries, district or provincial offices, NGOs, UN agencies, civil societies and faith-based organizations, academia, and external funders, among others. Determining the coordination mechanism and clarifying each stakeholder's role will reduce assumptions and duplications, while accelerating progress towards 100% WASH coverage in the country. Ultimately, the goal is for WASH in healthcare facilities to be self-funded. However, to reach the SDGs by 2030, external funding is necessary. For those of you who are in a position to fund WASH in healthcare facilities programs, here are a few things to consider. For WASH donors, include healthcare facilities in your community work. Reach out to healthcare facility administrators and community leaders, and consider partnering with those who are already doing work in healthcare facilities. For health donors, enact a policy that you will not fund work in a healthcare facility if it doesn't include WASH, or, at the very least, a clear funded path toward WASH. For all donors, sustainability is crucial. Will the project long outlive your presence as a donor? If not, how can it be revised to ensure sustainable WASH services? Finally, participation in the cross-sector coordination mechanisms will ensure that you're not duplicating efforts of other funders or the government itself. Thanks for listening. We hope this was enlightening and that you're excited for the webinar series. It's an opportunity to share and discuss experiences, challenges, successes, and lessons learned in WASH and healthcare facilities with those of you doing work on the ground, as well as those interested in taking action but haven't begun yet. We'll cover topics like, in policy, what is the system's approach to WASH in healthcare facilities for implementers in country? In evidence, what are the various assessment tools available on WASH in healthcare facilities? And practice, what are some examples of programs, like the Clean Clinics approach or the CDC WaterAid World Vision Mali project? Do you have a topic you'd like to discuss or present? Let us know. Email winhcfaction@emory.edu. For those of you who haven't checked it out yet, you can go to washinhcf.org, where WHO and UNICEF have put together resources and updates related to WASH in healthcare facilities. On a final note, we believe that a healthcare facility without WASH is not a quality healthcare facility. There is much work to be done, and hopefully through this webinar you've realized how important it is that we improve WASH in healthcare facilities globally. We hope you'll join the webinar series to share experiences and lessons learned. I'm Lindsay Denny, and thank you again for joining. This has been WASH in Healthcare Facilities, an overview.